Okay, part 2 of chapter 12, more on medication administration. The part of the text that covers the drug calculation formulas is really found in a separate PowerPoint. So if you're looking for more on that, look in the course page for the drug calculation and med math PowerPoint. That will give you a little bit more information on how to do some of these. The book does have good examples of how they're to be figured, and it sets up the formula as well. But for a little bit more info, look for the separate presentation. So in this part of chapter 12, we will actually talk about some of the techniques of administering the medication. So after you've figured the medication and know how much that you're going to have to potentially give, then you need to know how to actually give it. All right, so before giving any medication, we perform the history and assessment to determine the medication is indicated and not contraindicated. This is probably one of the most important steps in the medication administration process, because in many cases people are very quick to want to reach into the drug bag, but in many cases there are significant contraindications that maybe make it more of a risk than a benefit. So you need to ask things such as what medications is the patient currently taking, because there are in many cases are times that medications will have interactions with some of the medications that we may consider. A great example of this is Viagra. So if the patient is on Viagra and has taken Viagra within the last 48 to 72 hours, they should not receive nitroglycerin, or in most cases should not receive nitroglycerin because of the chance of causing a severe hypotension. Secondly, ask about any drug allergies, and being enough familiar with the variety of drugs that you carry and knowing whether or not there may be some cross allergies that come with those, or potentially is the drug a related family that you have that potential to run into. And finally, conditions that could contraindicate a particular drug. So now, like I said earlier in part 1 of this chapter, in most cases these are fairly high benefit, low risk drugs, but not always. Not always. I mean, the nitroglycerin and Viagra, for example. You must have a complete set of vital signs in almost every case before you get moving towards drugs. Some exceptions to this may be oxygen and subcutaneous epinephrine in the cases of a patient with severe anaphylaxis. You may want to get a quick pulse and respirators and hold off on the blood pressure, have somebody else getting the blood pressure and get that epinephrine administered immediately, because time is extremely precious in those settings. So, however, on the other side of the coin, certain cases, patients with hypotension, they will not benefit from the epinephrine because their blood pressure is too low. So if we have a systolic blood pressure lower than 70, the subcutaneous tissues really are not being circulated well enough to probably pick up that epinephrine. So it's kind of a judgment call. Documenting the procedure. Of course, you must document. Times are crucial, doses are crucial, all that information has to be present. That information also has to be passed along. So if you're not able to get your report done immediately, that's why it's critical to have some handoff report to the staff before the written report is done, so they at least know that it's occurred. Ask the patient if they've experienced a change in symptoms for which a medication was administered and any new symptoms. So this is a follow-up question, finding out how has this affected you. So after we've given one, we want to find out, is it benefiting you? Is it causing more problems? Or has it had absolutely no effect? Aseptic technique. When we're using aseptic technique to either puncture skin or to puncture a injection site on, say, an IV tubing, we want to do the best we can to make sure that that is clean so we don't introduce anything into the body. So in most cases we're using isopropyl alcohol. There are a few places that are using, actually quite a few places that are using chloropreps, which is a chlorhexidine mixture, which is another aseptic or antiseptic. And we're going to use that start in the middle, or where we're going to be most likely putting the needle, and working outward, working in a circular motion outward. So the cleanest point should always be nearest where we're going to stick the needle. So once you have disinfected, or if we're talking about either the skin or the injection site, do not touch that area. Allow it to completely dry, whether it's obviously whether it's either the skin or the injection port, and then do not allow equipment to become contaminated. So if you've swabbed it, don't throw it on the floor, or you run the risk of introducing more pathogens again. Of course, your safety is a significant concern here. Use your standard precautions. We do not recap contaminated needles. You should really not contaminate or recap needles at all if possible. If you must recap a needle, you have to use a single hand technique where you kind of scoop it up without any risk of poking your other hand or other body parts. But whenever possible, try not to recap needles and get the needle, use some of there's some engineering controls and some other safety devices that can be used along with, but get them into a biohazard or specifically a sharps container for needles as soon as possible. And if you can avoid puncturing the skin or doing much needle work in a moving ambulance, that would be recommended. Yes, we do have to do this sometimes, but it does increase our risk. So if we know that there's a stop coming up, maybe we choose to wait 10 or 15 seconds, get to the stop sign, ask the driver to hang tight for just a second until I tell you to go, and then do your puncture, and then move again, start transport. So here we have a case in which we're going to administer a sublingual medication. They're showing you that sublingual goes under the tongue. This can be difficult for some patients because of the fact that they will often not fully understand how to lift their tongue. It seems very simple to us, but you need to often tell them, put your tongue against the roof of your mouth, and then you put the pill under the tongue, or you give them a spray of nitroglycerin under the tongue, and then allow it to absorb. The patient should not chew the pill or the tablet. So oral medication administration, what is some of the things to consider here? What is the most common oral medication administered by EMTs? And there's a couple of those. Aspirin probably being the one classic considerations, the one pill that we more or less give the patient. Granted, in most cases it's a chewable, but is still an oral medication. People will arguably say that glucose, oral glucose, is another one. So yes, depends on how well and how conscious the patient is, whether or not they can appropriately maintain their own airway. Sublingual medications, we really only have one significant sublingual medication that we're going to administer, and that is nitroglycerin. Maybe in tablet form, or it may be in spray form, but sublingual medication most commonly given, again, is nitroglycerin. When we talk about nebulized medication, when we nebulize something, we take a liquid, or sometimes it's really kind of a superfine powder, but it's really mostly liquid. We run it in through a little device and have compressed air or pressurized oxygen flowing through there, and it turns it into a mist or droplets. As the patient then inhales, they're sucking some of those droplets excuse me, into their lungs and allowing it to be picked up by the respiratory membrane. In most cases, the medication we're talking about for nebulized medication is albuterol. Albuterol is a beta-2 agonist, and then in some cases we also have anticholinergic agents. We'll talk about what exactly those are later in the book, but later in the course. So nebulized medication in most cases is again going to be albuterol. This shows some of the equipment that's going to be necessary to do a small volume nebulizer, and what they have here is in the pack, the large pack there with the blue tube and the little blue thing, some white. That is the nebulizer that needs to be put together. You basically put the little white T-piece on top of the little canister, attach the blue corrugated tube out one side, and then hook up the oxygen tube to the bottom. And you can kind of see how this is supposed to look by looking at 299. The bottom picture there has that guy using the nebulizer. So additionally, you're going to need assessment tools and whatnot to fully do this. Secondly, check your medication and make sure it is the correct medication. It's not expired. You're going to assemble the nebulizer. Unscrew the cap of the medication cup and place the medication into the cup of the small volume nebulizer. Screw the cap back on. Select your oxygen liter flow. In most cases it's 8 liters. Some places will go 6, some places will go 10, but 8 is about perfect. 8 liters of oxygen. Generally will run a nebulizer for around 10 minutes or so. And then you will place, in this case, place the mouthpiece in the patient's mouth and have them close their mouth around it, breathe the medication in, try to hold it. If they can hold it, it will be the most benefit. It allows more medication to come into contact with respiratory membranes, and then exhale it. They can exhale through the pipe if they want. And like I said, normally this will run for somewhere around 8 to 10 minutes or so. Now we also have metered dose inhalers, which you may be familiar with from your time as an EMT. Metered dose inhalers are actuated. They're usually around 200 doses or 200 sprays per one of those inhaler canisters. And every time you push down on the top of the canister, it activates and squirts it out through the mouthpiece. Again, in most cases, this will also be a beta-2 agonist, probably albuterol as well. It's similar. It's the same medication. However, it's a different route of administration. The advantage of the nebulizer is it allows that patient to have kind of a continued exposure to that medication over a number of minutes to take effect, whereas a metered dose inhaler, basically it's the length of time that they can give it a squirt, inhale it, hold it, and then breathe it out, and then basically that medication is gone. So the metered dose inhaler does work. However, the patient that's more severely short of breath and not able to hold it for a short period of time there will probably benefit better from the small volume nebulizer. Now, we also have another medication that is given via inhalation, and it is nitrous oxide. Nitrous oxide is an analgesic gas, and it is a 50-50 mix with oxygen and nitrogen. So the effects of the drug is to slightly alter the mental status. So if you've had laughing gas at the dentist, that's exactly the same stuff. It's nitrous oxide. It helps to relieve a little bit of the pain, as well as kind of take a little edge off of the patient's anxieties while they are being treated. In many cases, it's used as a form of pain control, and that's what the analgesia refers to. And then we have injections. So we've talked about some of the less invasive routes of medication administration. Now we're going to move to the more invasive routes. When we're talking more invasive, of course, we're talking needles and giving an injection either via the skin as in the form of a sub-Q or an IM injection, or potentially starting an IV. So we're going to start out with talking about IM or sub-Q injections and then work our way towards the IV. So equipment used when you're going to give the patient an injection. First of all, standard precautions. Gloves are a necessary component here. You got to protect yourself. In most cases, there's minimal bleeding, but there will be the potential for bleeding. Secondly, alcohol, povidone, iodine, or a chloroprep, chlorhexidine, a syringe of proper size and with proper graduations, depending on the size of the fluid that we're going to administer, and then needles or filter straws in order to draw the medication depending on the package that we're getting it from. If we're taking it from a vial, we simply need a needle. If we're going to draw it from an amp, we're going to need either a filter straw or a filter needle. Additionally, we're going to need some gauze squares or adhesive bandages like Band-Aids. We will need the container of the medication, which is either going to be a vial or an amp, and we're going to get to that here in just a second, and a sharps disposal container. So we're going to need to give the patient, or get rid of the contaminated needle when we're done. Now, while I'm mentioning the amps and vials, I'll draw your attention to page 301 in your textbook. The picture number 1 there on 301 shows an ampule. What you don't see under his fingers is just, well, you can see what he's got in his fingers if you look into picture number 4. So the ampule is a completely glass container. We have to break the top off the glass container, and then we'll draw our medication out of that. A vial, on the other hand, has a rubber stopper in the top of it, as opposed to a big large piece of glass. And if you look at page 305, you will see a vial as opposed to the ampule. So when we're drawing medications from amps and vials, we hold it upright between the thumb and the fingers and shake downward to ensure that the medication is below either the neck of the ampule or the neck of the vial. If we're going to specifically draw medication from an ampule, we do not draw air into the syringe, and we do not inject air into the ampule. Look at the picture on 301 again. You know, picture number 4, that vial or that ampule is upside down. The filter straw that he's got on there is actually drawing from the broken neck of that ampule. So the surface tension will hold that liquid in there, so you can tip it upside down. If you inject air into there, though, you blow it all out, it all falls out, and you lost all your medication. So if you just stick the needle up in there and you draw back on the plunger, it will draw out the fluid. On the other hand, vials we do typically draw up the same amount of air as the amount of fluid we're going to withdraw. We'll stick our needle into the stopper of the vial, inject the air, and then pull back out how much fluid we're going to need for medication. So again, drawing up from a medication ampule. Here we go. We're going to tap the ampule and get all the medication down below the neck. Usually we'll take a piece of gauze or an alcohol swab, wrap it around the head and neck of the ampule there. I usually take the alcohol swab first and kind of swab around where it's scored or where it's going to snap, just to kind of remove any last potential pathogens that are on there. And then I actually, when I break AEMTS, I will take the foil package that the alcohol wipe was in and put that over the top of the ampule and use that to break. It's a little bit better protection in case something goes horribly wrong and the entire thing shatters. Normally this is how it breaks. It snaps off very nicely, very cleanly. It is going to be sharp, so having his thumb up there is kind of a risky move there, but snap the top off. Be careful not to spill any medication. And then 4, draw the medication into the ampule. Again, this is a filter straw, so it's going to catch any little glass shards that are in there. Do not inject air prior to drawing fluids. So when we're going to draw from now a vial, we're going to inject a volume of air equal to the volume of medication you're going to withdraw. So if we have a vial, maybe it has 2 milliliters of fluid in there. We only need 1 milliliter of that fluid. We'll drop 1 milliliter of air, put the needle in through the stopper, inject the 1 milliliter of air, pull out the 1 milliliter of fluid. All right, so techniques of medication administration. First of all, finding the places in which we can potentially inject. So they're showing you some sites here for subcutaneous injections. Now, when we say subcutaneous injection, most patients that receive insulin on a regular basis receive it subcutaneously, usually either in their abdomen or in their thighs. The easiest place in most cases for us to do a subcutaneous injection on a patient is to get some subcutaneous tissue off of the upper arm. And the best spot actually to do that is to go to the back side of the deltoid. The deltoid is the bigger muscle part right at your shoulder. Okay, so you go to the back of the deltoid area, or the back kind of the, well, where older ladies maybe have kind of a little flabby wing there. We're going to go back into that area right there, and we're going to pinch up some skin. And when we pinch that up, we usually will bring up some fat. And that's one of the best places, easiest places for us to give our sub-Q injections. Whereas if we're going for an intramuscular injection, here's another potential site, and we're actually looking at this from the back side, of course, not from the front side, so we're talking buttocks. Really, if you divide their buttocks into quadrants or 4 quadrants, we want to go up and out away from the tailbone area. So more up towards the crest of the hip. That's a good site to go. The other good site is using the deltoid muscle itself, except doing it directly coming straight at it, the arm from the side. So the muscle right below the shoulder joint, go a couple finger widths below where you can feel the bones of the shoulder, a couple of finger widths below, and you got a nice sized muscle there that you can inject most of your IM medications into. We have to be careful. So sub-Q injection, again, talks about the uppermost arm. Same thing with the IM. So here we have an example of the equipment we need for a sub-Q injection. You can see upper left, there's the filter straw going across. There's an alcohol wipe. And then one more time over is the syringe itself. It's a 1 cc syringe. The amp of medication, which is epinephrine 1 to 1,000, right in the middle of the screen. Adhesive bandage. And then bottom left there we have the actual needle that we'll be administering the medication with. Verify the medication, make sure it's everything that you're wanting, the right concentration, it's not expired. Take a look at the vial, make sure the vial isn't damaged, there's no particulate matter, which is what people often call floaties, but no particulate matter in the fluid itself. So obviously you snap the top of your amp in this case, just like we looked at a few slides ago. In this case, they chose not to invert the amp, and that's fine. You don't have to. You still should not inject air, though. So after you've cleaned the skin with alcohol wipe or povidone or chlorhexidine, you'll then pinch up some skin. I don't particularly care for the position that they're going here on this. They're actually going down by the elbow. But pinch up a fold of skin, hold the needle at a 45-degree angle to the skin, and insert the needle. Typically you need to insert the needle somewhere around 1/2 to 3/4 of an inch into the skin. Any further than that, you're running the risk of getting down into the muscle. However, with the way that Americans are these days, we do tend to have a bit more subcutaneous tissue. Now, there's a correction I guess you need to keep in mind here when you look at this slide. Is there's one extra step that isn't demonstrated here. You insert the needle, and then before injecting the medication, you pull back on the plunger ever so slightly to see if any blood pops up into the medication chamber there, or the clear part of the syringe. If blood comes back, that is probably not a good spot to inject that, because you've accidentally gotten it into a vein. Instead of making this an IM or sub-Q medication, you're fixing to make it a IV medication. If you don't get any blood to draw back in there when you aspirate or draw back, then you can go ahead and inject your medication then into the patient, and then placing an adhesive bandage over the injection site. And then finally, reassessing the patient. All right, so a couple other things I want to draw your attention to while we're talking subcutaneous. If we're going to give a sub-Q injection, we need to pay attention to a couple of specific parameters here. Number one, if you're looking on 301 and 302 of your textbook, under the subcutaneous injection area, it talks about you want to be able to pinch up a 1-inch fold of skin. That's about right. So if you can pinch an inch, then you probably have enough tissue there to do a good sub-Q. You can inject a maximum of 1 milliliter of medication subcutaneously, and you should use roughly a 23 to a 25 gauge needle, 1/2 to 5/8 of an inch long. That's the appropriate size of needles and the amount of fluid that you would potentially want to give. Now we'll move on to intramuscular. We may choose to give epinephrine 1 to 1,000 intramuscularly, although it's more probably appropriately intended for subcutaneous. The more commonly given IM or intramuscular drug by the AEMT is glucagon, and that's given to patients of hypoglycemia. It is typically given in the deltoid muscle site of the upper arm. And if you will look at page 305, picture number 4 there, you can see that they have selected appropriately the deltoid. We're going to see that here in just a second as well. So we're going to gather up our equipment we need. So a syringe, of course, the vial, as they show here, alcohol prep pad or 2. You need to swab the injection site as well as the top of the vial, Band-Aid, and the appropriate needle. You do not need a filter straw or filter needle for this because you're going through a rubber stopper. You're not breaking any glass, so you will not need a filter straw. So one more word on equipment before we go to this next slide here. Typically when we're talking about an intramuscular injection, we can use a little bit more medication. Usually we try not to exceed 1 milliliter unless we're going into the gluteus maximus, which is the butt. You can go with a little bit more, up to 2 or even 5 milliliters. 5 milliliters would be huge, be very uncomfortable. And then in most cases for an IM, we can use a 21 to a 23 gauge needle, or a little smaller in peds. and that needle length should be roughly 3/4 to 1 inch for most glucagon injections into the deltoid. If we're going to go deeper, say into a thigh, or we're going to go into the gluteal muscles, we could go up to 1.5 inches on our needles. But like I said, in most cases, glucagon is a 1 milliliter medication. You can easily do that in the deltoid. A 21 or a 23 gauge 3/4 to 1 inch needle is all you're going to need there. So you're going to select and verify the medication. In this occasion, they've actually chosen to select diphenhydramine, which is Benadryl, which you will not, at least at this point in time, will not be giving IM Benadryl to patients. You may be able to give them PO Benadryl, but not IM. So you're going to draw that certain amount of air into your syringe there. So if we're going to give 1 milliliter, we'll drop 1 milliliter of air. Insert the needle through the swabbed and clean stopper. Now granted, I should probably take just a second to point out to you, look at the top, the right side of this vial. There is a plastic safety cap over the top of it. That just pops off. You just kind of flick it with your thumbnail and that'll pop right off of there. And it'll expose the rubber stopper. So then that rubber stopper, you clean that with your alcohol wipe or chlorhexidine or what have you. Insert your needle with the appropriate amount of air drawn up in the syringe. Inject that air into the vial, and then of course the needle needs to be below the level of the fluid, so it needs to be, the tip of the needle needs to be in the fluid, not in the air above the fluid. And then you just will withdraw your medication from the vial. Clean the skin site. Probably, in reality, it's probably more appropriate for you to clean the skin site with some alcohol wipe, give it, and then start to drop your medication, because it gives it a moment to dry, and we do want it to have an attempt to dry before we just go jamming a needle right through it. So disinfect the skin site. Instead of pinching up skin, we actually kind of spread the skin, and it looks like and you might actually be trying to pinch up a little bit of skin here, but in reality we want to kind of spread the skin. So just stabilizing the skin, pulling the skin taut between the two fingers. Like if you have a smartphone with a touch screen now, if you spread your fingers out, it zooms in, or zooms out, zooms out. So you spread your fingers to kind of bring the skin taut. At a 90-degree angle, you will puncture the skin, and you need to go like roughly a 3/4 to 1 inch in. Again, pull back, draw back on the syringe plunger slightly, and they do mention that on this slide here. You should not be able to aspirate blood, and if you do, don't inject the medication. Remove the needle and start over. But if you draw back and get no blood, nothing comes back up in your syringe barrel, then you go ahead and inject your medication. Withdraw your needle, place it in the appropriate container, a sharps container. You can take a little piece of gauze and put it over the top of the injection site to stop any bleeding, or just simply in most cases apply a Band-Aid. And then of course you must reassess your patient. Make sure we get the effects that we want, and we're not going to have any super negative side effects. All right, and if we're going to administer an IV bolus or an IV injection medication, we're most commonly going to give one of two drugs, either dextrose for hypoglycemia or naloxone for a narcotic overdose or suspected narcotic overdose. We have to have either a running IV line, which would be a bag and tubing that runs to the IV and then into the patient, or a saline lock, which usually just has a little cap on the end of it. It may have a little bit of a pigtail of tubing, but a little cap. Sometimes we also have needleless systems. Hopefully we have needleless systems where we can reduce the number of needles we need, or sometimes we use a little plastic catheter, more or less, to penetrate the injection ports and then administer the medication that way. So if we're going to do the intravenous bolus medication, we're going to get our medication together. Here's an example of D50. That's a pretty good sized syringe. You can see they've had the glucometer out to check sugar and the alcohol wipe there. So you are simply going to have to assemble the medication after you verify it. So you double check it. Yep, says 50% dextrose. That's what we want. 25 grams in 50 mLs. So it's 0.5 grams per mil. You're going to assemble the syringe simply by screwing that plunger into the back there. So if we back up one, you can see that towards the attendant's right hand there, you can see that the gray stopper, more or less, the gray plunger part, is within the syringe already. And all that's left, if you look, it's kind of hazy, but look down towards the box that they're shown on the seat there. That's a threaded end that will just thread into the back of that gray plunger area. So you thread that in there and make sure that it's prepared. One thing that you additionally need to do when you're preparing it is, and they don't show this well here, but you will typically take the end of the syringe that's going to connect into either the needle or the port, and you will push out any excess air that is in the syringe. A lot of excessive air can create significant problems and cause something called an air embolus when we administer it to the patient. However, it usually takes a fairly significant amount. So if you have one or two extra tiny little fine bubbles there, it's not of great concern. We want to try to remove as much air as possible, but sometimes it's impossible to get everything out. So if we hold our syringe upright, and then we'll push the plunger, just very easily push the plunger. It will force out any air, because if we hold it upright, the air will rise to the top, which is where we're going to attach our needle anyway, and that's where the air will come out. Clean the injection port with the alcohol swab there, or other device. There are several devices out there that will help clean those up for you. Attach the syringe, and I'll back you up a slide here. You can see it's hooked in there, but if you look right there between the finger and the thumb, you can see there's threads on that little attachment port there. So there are also threads on the inside of the syringe where it is where you would either attach a needle or you can screw it in wirelessly. Needleless here. So screw it on there needleless. You crimp the IV tubing above the site of the administration. So in the case of an IV, between the syringe and the bag, you need to pinch it. Do not pinch it between the syringe and the needle that goes into the patient's skin. Then you're blocking moving any medication in there. So you pinch it to keep the fluid from, or the medication from, going backwards up the tubing. If we pinch the tubing usually pretty close to that injection site, it forces it to only go one direction. So after we've pinched off, then we are injecting the medication at the proper rate. I think I mentioned before, this is not a quick process when we're talking about D50. Obviously, discard appropriately in the appropriate sharps container. Flush the IV tubing and readjust the drip rate. So I talked about the roller clamp. I think actually in the last lecture we talked about the roller clamp, and that's what she has in her hand right there. Just a little roller wheel that goes up and down inside there to help regulate the flow of that IV. And then reassess your patient. And in some cases that means rechecking a blood sugar. All right, so our think about it here. After administering medications, you must reassess your patient and document the findings. Medications are intended to have good results, and hopefully that's what we're going to find, but they can have negative side effects as well. Ask the patient if he has experienced a change in the original symptoms or has developed anything new. So let's say we've given him nitroglycerin. You said you had 9 of 10 chest pain, 9 on a scale of 1 to 10 chest pain, and then we gave you that nitroglycerin about 2 or 3 minutes ago. How is your pain now? Describe your pain. It's gone down. Now it's a 6 or it's a 5, or maybe the pain's actually gone up. So that's the information we want to know. We want to see if what we did worked. And then we also want to get a subsequent set of vital signs trending One set of vital signs on a patient that we put in the back of our ambulance and take somewhere is not enough. No less than 2 sets of vital signs on a transport, and that better be a short transport. The more you do, as far as treatment-wise, the more sets of vital signs you should probably have, simply for the fact that we need to see if we're having any effect. All right, so that wraps up the second of 3 lectures. If you have not read the textbook up to this point, you need to go back and read the textbook. We'll move now to the next and final section of this chapter, which is as starting an IV and initiating interosseous access.